Hello, this is a video lesson on radiation protection, part 17C on personnel protection. We're going to talk about factors that affect occupational dose, the pregnant occupational worker, occupational shielding, the NCRP dose limits, dosimeters, and occupational monitoring. So as far as factors that affect occupational dose, if we compare the radiologist versus the radiographer's dose, the radiographer's dose is much lower, significantly lower. In fact, the radiographer exposure rarely exceeds 0.7 millisievert per year. Fluoroscopy is the highest occupational exposure for all diagnostic X-ray personnel, and the second greatest is mobile radiography. The best position for the X-ray tube during mobile fluoroscopic exams is below the patient. As we can see in the image on the left-hand side, the X-ray tube is beneath the patient, and the scatter radiation is headed toward the floor. In the picture on the right-hand side, the X-ray tube is above the patient with this imaging unit, and the X-rays are then the scatter radiation is going to be headed towards people's faces, occupational and non-occupational workers' faces. So it is better to have it below the patient. Another thing is where the surgeon stands during the procedure. So the best place to stand is where the image intensifier is, not where he's standing, which is by the X-ray tube. If you're standing by the X-ray tube, the scatter is coming back from the patient to that person who's standing here, standing at this position, and also the X-ray tube is emitting leakage radiation, so they're getting doubly exposed. So the best place to stand is over here by the image receptor. Another thing is considering the positions to stand during fluoroscopy. So the radiologist is receiving 15 milligray during this procedure, the C-arm procedure, but if the occupational worker standing behind, the technologist standing behind them, they'll receive 0 milligray. If they're standing to the side of them, they'll receive, for example, 1 milligray. So it's just a matter of standing in an appropriate location. But of course, distance is helping the technologist in this case as well. So the idea is that if you have the X-ray tube beneath the patient, that strong scatter radiation is going to be aiming at the floor. That's a better place for it to be. ISO exposure lines is that where the protective apron is where they're going to receive 3 milligray per hour at that position for the radiologist or the RA. If you look at the ISO exposure curves, this is a fluoroscopic unit. They would receive 500 milligray per hour if you stand right by the unit, 50 milligray if you stand back further, and 5 milligray per hour if further yet. So just looking at those locations, then it's important to note that those ISO exposure curves are very important. During mobile radiography, who should wear a protective apron and have a radiation dosimeter? That would be the technologist. And an apron should also be provided to anyone who assists with the procedure. Most items designed to minimize patient dose are also going to reduce occupational exposure. The only exception is filtration because it only protects the patient. In diagnostic imaging, at least 95% of the radiographer's occupational radiation exposure comes from fluoroscopic and mobile radiography. Fluoroscopic is by far the highest, and then mobile radiography is second. Important aspects of occupational radiation control, the cardinal principles. So we have 3 cardinal principles, which are time, distance, and shielding. And we have the ALARA concept, which is as low as reasonably achievable, that we always have to maintain to make sure that we're keeping our dose and patient dose and everyone else's dose as low as reasonably achievable. What is the most effective means of protection for the occupational worker? It is distance. The inverse square law informs us of that if we increase our distance, we're going to decrease our intensity greatly. Reducing exposure during fluoroscopy, for one thing, minimizing X-ray beam on time. That's an important one. Pulse fluoro, that's going to be a huge assistance. Recording fluoro time is important, that we're recording for not just the patient, but also for the occupational worker. The radiographer should step back when immediate presence and assistance are not needed or required. Remain as far away from the patient as possible, keeping the front of the apron facing the radiation source at all times. And then finally, the last image hold, as it helped with the patient, is going to help with the occupational worker, because the radiologist doesn't have to go back and put the beam back on again to get an image on the monitor. So last image hold is very important for us as well to decrease our dose. To reduce exposure during mobile radiography, the protective aprons are assigned to portables. We should wear aprons during all mobile exams. We should maintain the maximum distance from the source, which is the X-ray tube, and from the patient. The exposure cord length should be at least 2 meters, which is 6 feet. And the primary beam should never be pointed at the occupation or on non-occupational workers. So to reduce exposure during radiographic procedures, the useful beam should never be directed toward the control panel, because we're going to be aiming it at ourselves. The mechanical restraining devices are important to use versus having someone hold the patient. And if we're going to hold the patient, it should never be the occupational worker. It should be a family member or a friend, first of all, and then a non-occupational worker, secondly. So the pregnant occupational worker, when a radiographer becomes pregnant, she should notify her supervisor, but it's not mandatory. This is a volunteer process. She would be then counseled by her manager. A wraparound apron is recommended so that there's no possibility of getting dose in the posterior aspect as well. 1 millimeter lead equivalency lead aprons are available, but are not necessary. There's more concerns about back problems during pregnancy that constitute a greater hazard than radiation exposure. So 0.5 millimeters lead equivalency aprons is more than sufficient. After declaring pregnancy, a second, which is a fetal personal monitoring device, is provided. She would, if standing out, she would still wear her apron, her badge at the collared level, which is her whole body exposure. And the second monitor would be assigned to the fetus, embryo fetus, and would be worn under the protective apron at all times. The dose of the embryo fetus is near zero. Attenuation by the maternal tissues overlying the fetus reduces the dose to the fetus to approximately 30% of the abdominal skin dose. So report 102 provides equipment regulations for using X-rays up to 50 mega electron volts. So with this report, we're finding that this is going to be equipment regulations such as filtration, as well as the protective aprons and that kind of thing too that we'll be looking at next. So occupational shielding involves protective aprons, which are 0.5 millimeters lead equivalency. They should be worn during fluoroscopy and mobile radiography. If they worn in interventional suites, should be of the wraparound type. Gloves, which are 0.25 millimeters equivalency, should be worn when the hands must be protected from the beam. In other words, they're in the X-ray beam. The neck and thyroid shield, 0.5 millimeters lead equivalency, should be worn in specials in fluoroscopy, but it's not required. Protective eyeglasses are not required either, unless you're going to receive really high doses, like in interventional. But the cleared lenses are a minimum of 0.35 millimeters lead equivalency, and wraparound frame lenses are 0.5 millimeters lead equivalency. When not in use, protective apparel must be stored properly on properly designed racks to prevent cracks, and protective aprons and gloves should be fluoroscoped or radiographed at least annually to check for cracks. So the radiation dose limits, you'll need to know your occupational dose limits for radiation workers, the non-occupational public dose limits, which are for non-occupational workers, and the embryo fetus dose limits for the embryo fetus of the occupational worker. And we'll be taking a look at that on our review sheet when we do our worksheets. So dosimeters is the measure of the radiation intensity is called dosimetry, and the radiation measuring devices are called dosimeters. They're going to monitor, the monitor itself is going to measure the exposure of the radiation to which the monitor was exposed. And the three types that we're going to talk about are the film badge, the TLD, and the OSL. The film badge uses film to detect radiation, and it has a holder with copper and aluminum filters. The TLD uses lithium fluoride to detect radiation. It's a stationary area monitoring and radiation therapy. It's used for patient and personal monitoring. In radiation therapy, the TLD is used to record patient dose. It has a three-step process in which the X-rays strike the TLD material, which is the lithium fluoride. Then it's sent off to a lab to get it analyzed. And at that point, we have it hit with heat, which is the thermoluminescent. That's the thermo. And it's going to emit light, which is the luminescent. And that photomultiplier tube will then measure the light. And that'll be equivalent to what the dose was to begin with. The key to the TLD is that it is reusable. With the OSL, it uses aluminum oxide to detect radiation. So the person, again, is exposed to radiation, specifically their badge. Then we're going to send it off to a company to get it read. We're going to have a laser that strikes the badge. It will emit light, and then it's going to be measured by a photodiode. One thing about the OSL badge that's important to note is it can be reanalyzed, which means it can be reassessed. High sensitivity, it means that an instrument can detect very low radiation intensities. The lowest levels that these instruments can detect is the film badge can detect 0.1 millisievert, the TLD can detect 0.05 millisievert, and the OSL can detect as low as 0.01 millisievert, which makes the OSL the most radiosensitive of the three dosimeters. Occupational monitoring. This is required when there's a chance that a person will receive more than 1/10 of the dose limit. Clinical situations in which it's advisable to wear more than one personal monitor is the abdomen during pregnancy, which would be the fetal badge, and extremities during interventional radiology and nuclear medicine. So they would wear the ring badges, or they can be wrist badges, but usually it's ring. And so this is an example of a radiation dosimetry report that provides the information with regard to the period that of the dose, the quarter, which quarter that they're in, the year, and then the lifetime dose limit as well. And it provides the person's name as well as what type of badge they're wearing, and then it's where they wear it at the collar, for example, and that kind of thing. And then the control badge is on here as well. The purpose of the control monitor is to measure background radiation during transportation, handling, and storage. It should never be stored in or adjacent to a radiation area, but rather in a distant room or office. Any dose on a control badge must be subtracted from each individual monitor. And this concludes our video lesson on personnel protection. Have a great day.